our presentation today, Substance Abuse 101.5. And I'm just pulling up your bio here, sorry. So John has served in multiple areas of social work and community work over his 24-year career in mental health and substance abuse services. He obtained an MSW from Indiana University in 2001 and an MBA from Western Governors University in 2013. He's currently the Vice President of Adult and Addiction Services at Oaklawn Psychiatric Center. So, John, we welcome you today and I look forward to hearing your presentation. And we thank everyone who is joining us today for their interest in what you're going to be talking about.
Well, thank you. I appreciate the introduction and mostly the opportunity to come and present. We are going to talk about substance use disorder today. And when you talked about things getting worse during the pandemic, definitely substance abuse has been a really big issue and a challenge to treat. You know, some of you have heard the commercial that says this, but I also agree that, you know, substance use isn't about, you know, recovery is not the exact opposite of an addiction. Connection is the exact opposite. And so during COVID, connection is what we've all been missing. And so people with substance use disorder have had a really hard time with connecting. We see that in our services, the amount of people being able to engage in treatment, but also in our overdose deaths. We have just seen a complete spike in those, not only locally, but nationally. So COVID has had a huge impact. So we'll talk a little bit about substance use and why it happens, and then some approaches that are helpful. And then we'll stop about 12:50 or so and answer any questions. So I do think that the chat is being moderated. So if someone would like to just type in their question as we go through, we'll see if we can answer those at the end.
Yes, John, I'll monitor those, but if everyone can mute, that would be great. You're a little bit of background noise.
All right.
Thank you.
So a big piece of substance use disorder is neurology and how the brain chemicals work together. And as you can see, here's a rudimentary picture of the brain just with the basic stuff. And there's a couple of pathways here that are very important in when we talk about substance use disorder. The reward pathway is very important, the memory pathway, and then of course pain pathway. And then of course you all know that neurons are the thing that fire to make those pathways happen. And what we know is that the brain can be rewired. And so with typical substance use disorder, over time, we actually see these neurons creating new connections, and old connections that are needed for the purposes of recovery sometimes get undone or unwound. And so the brain literally gets rewired through this process. Another thing that happens in the brain and how it communicates is through neurochemicals. And with addiction, it's all about the dopamine. Doesn't really matter what the chemical is that they're using. It's about the dopamine. As you'll see here, you know, the dopamine is transmitted across the synaptic cleft, which then creates the feelings of euphoria. Now, when it comes to dopamine and addiction, it's important to know that anytime you enter a chemical into your brain, it actually will force more dopamine to come out than natural. So it goes above and beyond what naturally can happen.
I'm going to do two things.
So it's a complex illness when we look at how it interacts with the brain and then how it interacts psychologically and sociologically as well. So again, we're looking at this reward pathway, and you can see how the different substances here affect the reward pathway. What typically happens is the use happens and the reward pathway in the limbic system gets super charged, and that dopamine starts flooding the brain, and then it gives feeling, it really reinforces it. In the case of people with substance use disorder, it reinforces it at a greater level than people without substance use disorder, which causes the reinforcement kind of thing where they get compulsive about using the substance. So what happens typically is the substance is used, and in this case, this would be a cocaine, and then it comes in and mimics neurochemicals and attaches to those receptors, which then causes a chain reaction, which is what creates the euphoria. So here's how it affects the brain. Here is a brain that is not on substances. So the red really shows a lot of activity in the brain. And this brain here shows a person who has been on substances, probably in really early recovery. And so you can see that the brain doesn't work as well or fire as efficiently as it would without those substances. Again, here's a control brain. Here's a brain that's on cocaine. So you can see pretty dramatic decrease in functioning between the two. This slide, the one on the lower right, is even more profound. Again, you can see here the brain activity with the red and yellow. It's pretty good, but this is a cocaine abuser 10 days into abstinence. And you can see that not a lot of brain functioning has returned, but some has. And then you can see 100 days passed. So this is where I like to talk about the fact that detox isn't a cure, it's a start, because the typical detox program will be 3 to 5 days. Even if a person goes inpatient, they're looking at about a 30-day stay, which, as you can see here in the brain, isn't enough to completely heal and restore the brain back to the functioning that needs to happen. So it's important that when folks start their journey to recovery, that it's not just about a detox, it's not just about a short stay in a hospital, but it's about a longer term recovery process. What we do know is that if a person can stay engaged in a treatment episode for a year, then their long-term outcomes for abstinence or decreased substance use over the rest of their lifespan is really great. So it is all about that follow-up care and that follow-up connection that they'll get. So addiction works on primary memory, and this is my dog Blue, and Blue loves that synthetic bone there. And you know, at any point in time, I can tell Blue to go get his bone, and he'll go to the exact location in the house where that bone is. He always remembers where the bone is because that gives him pleasure. So addiction is kind of like a dog with the bone. You know, it gnaws away, and people get events associated with it, sights associated with it, smells associated with it, feelings associated with it. And so it's just this process by which it's always gnawing and the memory stores it. We're going to talk a little bit about how the memory stores it neurologically, but where it stores it is in the amygdala, which again is in that limbic system area. And they did a study in which they showed individuals a nature video and seeing how much their amygdala lit up. And then they did another one on showing a using video. It happened to be cocaine. and then seeing how their amygdala lit up. So you can see with the nature video, the amygdala here wasn't lit up very brightly, but when they showed the cocaine video, the amygdala lit up really brightly. And so what that tells us is that this person is experiencing what we call euphoric recall, where they're remembering in their internal long-term memory what it felt like to use cocaine, and all of the good things about cocaine. So one of the things about substance use and the rewiring of the brain that I was talking about is that it becomes over time more and more difficult for people to connect the consequences of substance use to the actual use. So over time, when this amygdala lights up from a trigger, again, could be a sight, a smell, an internal emotion, something they hear, some music, anything, some area of town, whatever lights this amygdala up, then it really, their brain kind of goes into, okay, where's the drug and how can I get it and where can I use? And they're not really thinking through the consequences. So one of the things that treatment does is, it really helps them think through consequences, thinks through tools to delay to filter information through that frontal cortex so that they can start thinking about consequences and then making a better decision around what they're going to do with that craving at that particular time. So again, that constant engagement of that frontal lobe is what restores those synapses and that neurowiring. So learning is really significant in the brain. Our brain is a pretty magnificent recording machine. We remember all sorts of stuff. And so, it is a little bit about that behavioral theory of Pavlov. For those of you who will remember, Pavlov is the one who had the dogs. And every time he fed the dog, he rang the bell and measured their saliva response. And over time, what happened was he didn't even have to introduce food. All he had to do was ring the bell, because over time, the brain remembered that the bell meant food was coming. And so again, when we're thinking about triggers and we're thinking about sights and smells and internal emotions and things of that nature with folks who have substance use disorder, it really is about this bell that rings, and then they're automatically in that euphoric recall and remembering those good times. So as you can see, this is a very complex disorder that transcends choice at times. It transcends, morals or values, and it really does, operate in the same way of other mental health disorders that we find in our DSM. And so this is a very complex disorder to treat. And I think sometimes we forget that, especially for people who don't have a history with substance use disorder, that, the answer is, well, just stop. But clearly it's way more complex with just starting. The other complexity about substance use disorder, like many mental health disorders, is it actually impacts the whole system, right? Not just the person, but the whole system that they're involved with. And so when somebody comes in early recovery, they typically have high needs. And here are all the needs that they could have, and many of them need most of these things when they come. So, when we're treating substance use, we're looking at a good intake or assessment. So we can look at that ASAM criteria and give them a recommendation on what level of care they may need. Sometimes it involves behavioral therapy and counseling. Obviously, drug testing is very important because that tells you what the progress is. And then case management. Many times, especially with opioids, we need medicines on board. to help the brain kind of calm down and rewire a little bit and give people an opportunity to develop skills and neural pathways that are different from what they're used to. And then, of course, peer support and self-help are very important because, again, the opposite of addiction is connection. And so that's why we encourage those things. And then this continuing care portion is really important. For one, like I said before, we try to keep people engaged for about a year because we know the outcomes are better. And, you know, having constant checkups. This is a chronic illness. People typically don't just have one bout of this through their life, but this is something that is something that they need to manage through their whole lifespan. And so sometimes there are lapses. You know, we will see people who have had 20 years of abstinence, and then all of a sudden, you know, an event hits, and they're returning to alcohol or they're returning to drugs because that's what their brain is telling them. And so, you know, we want them to have those checkups and those connections so that if there is a lapse, then they can quickly get back into treatment and get back into connection to make that lapse as short as possible so that the brain doesn't continue to rewire and deteriorate over time. So when it comes to treatment, the important thing is to know that there is no single treatment that's appropriate for every individual. You know, there are lots of pathways to sobriety. You know, obviously when you get an assessment by an addictions counselor or addictions person, you know, they'll talk a lot about your treatment options. You know, do you do an inpatient? Do you need a detox? Do you do an IOP? Can we do this individually? What is the thing here? But the reality is that no single treatment is appropriate for every individual. And so that's why it's good to have multiple treatment centers. And in those centers have multiple groups that address different things. For instance, we have groups at Oaklawn that address opioid specific issues. We have groups that are women only. We have groups that are that deal with trauma and substance abuse. We have groups that deal with criminal thinking and substance abuse. And so, you know, we have groups that encourage abstinence and groups that are more harm reduction groups. We have groups that help people with straight substance use, and then we have groups that help people that are dually diagnosed with other mental health issues. So not every treatment approach is for everybody. And I would also say that not every support group is for everybody. So, you know, 12-step groups have a long history of helping people. And certainly we recommend trying out 12 help groups. But there's also other things. There's Celebrate Recovery. There's Recovery Church in our community. There is, you know, peer support groups. There's all sorts of, there's Smart Recovery. There's all sorts of ongoing peer support kind of groups that can help people progress in their recovery and then stay with their recovery over a long term. It's important to know that effective treatment attends to multiple needs of the individual, not just his or her drug use. Very important to address trauma. I always say that if you didn't have trauma going into a substance use disorder, you definitely have one coming out, because maintaining a substance use disorder is a traumatic thing. Traumatic things happen to folks with substance use disorder. You know, their children's lives get interrupted, they lose jobs, they go to jail, they lose relationships with family. Sometimes very traumatic things happen in the process of obtaining use. In order to get the drugs, there may be traumatic things that they have to subject themselves to. So it's important to address that need. But you really have to look at the whole package. You know, what do their kids need? How do we involve the family? What are their vocation needs? What are the things that we have to put in their place so that they can start to completely rebuild their life And so it's important that we're not just focused on abstinence from the drug use, but that really recovery is a process where many of your domains in life have to be enhanced and restored for you to have a long-term recovery process. So again, treatment has to address medical needs, has to address psychological needs, social, vocational, and legal problems. Again, if we're not addressing all of those key domains, then we're setting a person up for repeat exposure to substance use. So where to start? Well, you know, this is the question that everybody has who has substance use disorder, or who has a family member or a friend or a community member that they have connection to. Where do we start? Do they have to go into a detox center? Can they do something outpatient? Do we start with a 30-day inpatient program? And again, not everything requires those levels of care, and not everybody will require those high levels of care. I will say that it is important with alcohol and benzodiazepines that there is medical evaluations on board, because those are very dangerous substances to detox from. It can cause seizures and then ultimately death if not appropriately dealt with. So, you know, those substances, we typically do talk about, you know, a detox period of time. Sometimes we can manage that with a physician on an outpatient basis. Other times we really need to have, you know, a detox center manage it because it's medically complex. Opiates often need a detox plan and medication to move forward. When we review the fatalities from opioid overdose, what we notice is there's a lot of fatalities from people who stop using abruptly and it gets out of their system, and then their tolerance decreases, and then they reuse again. And then because their tolerance is lower, that's what causes the overdose. Or they've been in jail and they've not been engaged and they've had a forced withdrawal because of that. Or they've been to a treatment center and didn't start on any medication assisted treatment while they were there. So opioids oftentimes will require medicine, whether that's buprenorphine or the brand name is Suboxone, or sometimes naltrexone can be used effectively. Sometimes methadone is what's needed, but there's medication is really important when it comes to opioids. And of course, we always detox with caution. When we see people with opioid use disorder, we often do talk about how are you going to stop, and what do you need to stop, and what's your plan for medications, and how can we help you with that plan, and so on and so forth. Because again, we don't want to set people up for failure and then have a bad outcome. So detoxification safely manages the physical symptoms of withdrawal, but again, does not solve the addiction. You know, research study after research study has shown that detoxes are not an effective way to cure addiction or to say that the disorder is over, but it is oftentimes a good place to start to manage the discomfort of that. There's also a myth out there that says, well, people should go through a hard detox and that'll kind of teach them. But in reality, it doesn't have any impact whether you white knuckle detox or you do a more comfortable medical detox. In reality, it has no impact on whether you relapse or not. In fact, the white knuckle detoxing often relapses at higher rates than the medically managed detox. And the reason for that is because of the euphoric recall. And the more painful the detox is, the more the brain is actually craving the substance. And so, you know, detoxification safely and comfortably manages those symptoms of withdrawal, which is often important. Again, I can't emphasize enough, this is the first stage of addiction treatment. Some people don't need this stage, but when they do, this is the first stage, not the absolute end. And again, it does little to change the long-term drug use. So once a person has detoxed from the chemicals, it is important then to engage in a recovery process by which they can then continue on not using drugs and not introducing them back into their system. So comprehensive long-term treatment is important because over time, psychologically, addiction becomes a coping mechanism and a problem. So it is a way to solve problems, but it also creates problems. And so in later stages of addiction, this is how people envision their problems being solved. You know, I lost my job because I went there intoxicated. Well, how I'm going to not feel the consequence of that is I'm going to continue to be intoxicated. So again, it's a way to solve a problem, but it also creates them. I remember working with a lot of parents who had children in the DCS system. And it was often very frustrating that they would have, you know, just great recovery going, abstaining from drugs and alcohol, very invested in social supports. And then the closer it got to the return of their children into the house, the more at risk they were. And that was simply because they were kind of worried about, oh my gosh, will I ever be in trouble again? What will my kids do? What kind of stress will the kids bring back to my life? How will I parent? Am I a good parent? You know, all of these questions. And so if they're not handled correctly, then they revert back to the coping mechanism, which then again just creates another problem, right? So it's a pretty vicious cycle, and it takes a long time to kind of reverse that cycle and introduce new mechanisms into that cycle that will reduce the using of that coping mechanism. So when they're in counseling and behavioral therapies, this is some of the things that we look at teaching them. So replacing drug using activities. So we know, if we go back to that neuroscience, we know that a lot of drug using is a result of that dopamine. So we're introducing things to people that talk about how you can naturally get dopamine and also think about the realistic. So there is no natural way to have dopamine released at levels in your brain that cocaine will give you. But that also doesn't mean that you have to live the rest of your life miserable. So we'll talk about, you know, taking care of yourself, you know, exercising, eating well, involving yourself in a spiritual journey if you're so inclined. You know, all of these things that will help the dopamine in our brain kind of naturally soothe us. We talk about drug resistance skills. So this would typically be called relapse prevention. This is just talking about how you manage the signs and symptoms of triggers, how you manage those high-risk situations, how you manage that first, you know, company Christmas party where they're going to have alcohol, how you go to that wedding and stay sober, how you deal with this unpleasant event that's happened in your life, how you deal with that person who randomly calls you that you used to use with that wants to go use, you know, all of those skills needed to resist that. We do a lot of motivation work as well. Because recovery is a long-term process, people have motivation that wanes and their ambivalence goes up and down. I often talk about the fact that it's no different than other changes that people make in their life. I know that I have had periods of time where my motivation to change certain behaviors has been very high. And then for some reason, I lose motivation, and then I'm kind of right back into trying to figure out how to stay motivated again. And so motivational interviewing is a great technique to use to help people maintain motivation and working on that. So, you know, people in early recovery need a lot of encouragement and a lot of support, because one of the things that happens is that all of those psychosocial stressors start to catch up with them. You know, their credit history, their finances, their employment records, their old relationships, all of this starts to hit them in early recovery, and they're kind of, for once, kind of comprehending what an impact substance has had on their life. So it's easy to give up and it's easy to lose motivation. And so that's where treatment kind of does the attaboy or attagirl kind of thing to help keep them going. Problem solving skills are very important to develop. And so, you know, engaging that frontal cortex during the treatment process is very important, because again, substance using is a coping mechanism and a problem. So in that using brain, we solve our problems by using, it's a quick fix. So, you know, oftentimes we'll talk about quick fixes versus long-term solutions, and constantly process how we work through our problems and what's a reasonable way to do that. The last thing we work hard on in treatment is interpersonal relationships. Again, connection is so important. And so how do we navigate those relationships that we've impacted negatively with our substance use? How do we restore those things? What relationships should we be working on? What relationships should we, you know, leave alone and let time dictate which way it goes? So all of these behavioral therapies, these evidence behavioral therapies that we use will be addressing these problems. So just a little bit about medication-assisted treatment. Here is some examples. And the reason why I like to talk about this again is just to stress how important it is in opioid treatment. And again, you know, everybody has opinions on these medications. But honestly, you know, in the end, what medication is good for the person is really up to them and their physician. And so we really need to be supportive when they're taking more steps. There's a lot of myths about medications for drug addiction. One of those myths is, well, aren't we trading one drug for another? And my answer is no. You know, trading a prescribed medication that's controlled by a physician and controlled by a pharmacy, that's taken as it should be, versus taking a street drug in an uncontrolled way that doesn't contribute to the stabilization of your life, you can't compare those two. So obviously, some of these medications do calm down those receptors that cause craving. Some of these medications are more long-term, some are shorter term. But again, that's up to the person and what they need, and how they progress in their treatment. Obviously, some of these medications can be abused, but you know, there are techniques that are utilized to help curb that. You know, again, drug screening. Sometimes we'll do something called short scripting, where, you know, we don't give a 30-day supply of these medications. We may give a 2-day supply, and then you need to come check back in with us. And that's what the person needs to stabilize. So these medications are very important and very helpful in terms of recovery, but also in terms of preventing deaths and overdoses as a result of not having those. Do you really have to want it? I really love, you know, I love motivational interviewing. And so a lot of the things that, or when people say that you really have to want it in order to get it, I always have to say, well, you have to be willing to talk about it. You have to be willing to engage in a process. But I love what I heard in a motivational interviewing training once, that, you know, if you take a horse to water, it's true, you can't make them drink, but you can make them very, very thirsty. And I love that kind of analogy when it comes to individuals' motivation. So effective treatment doesn't necessarily have to be voluntary. What we find is that what brings most people into drug treatment or some type of contemplation about recovery are adverse things. You know, when the cost of continuing to use outweighs the cost of stopping, then people start to get into a contemplative state about, should I continue this behavior or not? So, you know, oftentimes the loss of a job, or being involved in a criminal justice situation, or the threat of a relationship being lost, or a medical problem, oftentimes will precipitate somebody really making an earnest effort at needing recovery. I love what the criminal justice system does with problem-solving courts, because drug courts, they have drug courts in St. Joe and Elkhart County. They're both very, very effective. And these are courts that are specifically designed to help keep people motivated. You know, on one hand, if you do well and you do what you need to do, then there's these great rewards, like, you know, you don't have felonies on your records. On the other hand, if you have blips along the way, there's a very quick and swift judicial response that also helps people make the connection between the consequences of using and the consequences of recovery, which are very different. So when we look at people who are quote unquote forced into treatment or coerced into treatment in some way, shape, or form, the outcomes are very similar for those who have legal pressure versus voluntary. When I was doing a lot of clinical work, I had a mixed group of people. Some were legally referred, some were not. And I always got the thing from some people saying, well, I'm voluntary here, so I don't have to be here. And I always make the point that everybody is voluntary here, because not everybody, just because a judge says to do it, doesn't mean they're doing it. So, you know, when we look at it that way and give people the break, what we see is the underlying problem of substance use becomes what we all work on together. So there's equal success rates between those with legal pressure and those that are voluntary. So when we talk about effectiveness of treatment, we really do have to think about what is success. What is the goal of treatment? So the goals of treatment should be to return back to productive functioning. You know, if we can reduce the drug use by 40 to 60%, then we notice that, you know, we can also decrease crime. We can increase functioning. So sometimes, you know, people are all or nothing thing around substance use, but, you know, treatment sometimes helps people reduce their use, or it gets them off of extremely dangerous substances, which then gives us some more time to work with them. So treatment also reduces crime by 40 to 60%. Treatment increases employment prospects by 40%. And drug treatment is successful in treatment of diabetes, asthma, and hypertension. So, you know, there's a lot of myths out there that says treatment is not effective, but as you can see, it's very effective. In fact, it's effective as other diseases that we might treat that are chronic. So, you know, treatment's important. The other thing I would say is repeated treatments can be helpful. You know, one of the things that I often work through with family members is, you know, I don't know what to do with this person. I'm like, well, what do they want to do? Do they want to go to treatment? And they'll be like, oh, I've tried treatment over and over and over. And every time you go to treatment, you learn something new and you're taking a step towards that goal of recovery. And so even repeated treatments is actually the norm, not the regular. I was talking to some of our recovery coaches this week, and there was a program that they're working in, and one of them went to one of the people in the program, decided that they were going to go to detox and then go to inpatient. So they did. And then they returned back to this housing program and did not stay sober. And so the person that was running the housing program was like, well, that didn't work. And the recovery coaches were really quick to remind the person that, yeah, it did work, because now the person's thinking, how am I going to get sober again? How am I going to get back into a recovery process again? And they were able to relay some of their stories, that every time I went to detox, I heard something different that helped me. Every time I went to an AA or an NA meeting, I heard something that helped me. Every time I went to an IOP, I heard something that helped me. And so ultimately their recovery was this kind of conglomeration of all of the stuff that they had been doing over the years in order to reach a drug-free life. And so that's really how we have to measure the effectiveness of treatment. Does it keep people motivated and on the right track? And are they progressing in some domains of their life with each and every episode? So again, this is a integrated recovery model, just another way to conceptualize recovery. You know, there are stages of recovery that we look at here, and you can see way down here, this life balance, personal growth and development is way down the line in recovery timelines. So again, just reinforcing that not using drugs and alcohol is only the beginning of this process, that it takes a long time to get fully restored back to where you want to be. So when you're treating substance use or you're trying to intervene in substance use, there are some really great skills that you can use. First of all, you know, having good assessment skills. So I know that there are some clinical people on here. You know, it is good to be able to, even if you don't directly treat substance use disorder, really become aware of that ASAM criteria and how to assess for it, so you can get your patient to the place that they need to be right away, rather than, you know, the wrong kind of treatment for them. Being proficient in motivational interviewing is really key. There's some free training on IPGAP. It's the Indiana Gambling Prevention website. I would suggest that as a kind of teaser, you could look at that in terms of motivational interviewing, but there's a lot of resources out there that teach motivational interviewing, but it is a key skill to have. Understanding comorbid disorders. Obviously, most people do have depression, anxiety, and other mental health issues that go along with this. Being able to recognize what stage of change they're in and what's needed in that stage of change. So kind of thinking in this as a trans-theoretical framework, where if they're contemplative, what is it that I need to be working with them on? Because again, it's not always an all or nothing. You're either going to do it or you're not, but it's a process, and that's how we should look at that. Do they have access to medications? And are we able to help them manage trauma-related symptoms? And I just put some evidence-based treatments for that trauma. Seeking Safety is a really good place to start. Seeking Safety is a program that addresses substance use and trauma. And again, you have to be able to address trauma and be sensitive to that if you're going to make headway on a substance use disorder. So they got to learn to self-soothe. We've talked a little bit about this. Got to increase those social supports. Again, in it for the long haul. So it takes 1 to 2 years of good treatment and good connection, oftentimes, for people to really get on a good pathway. They got to be willing to learn new skills that they didn't learn if their use started really early. And they must learn how to manage relationships. Well, that's all I have. I'm going to take questions and answers. Well, I'm going to take questions. If you want to give me some answers, that'd be great too. You can feel free to call me or email me anytime you want. But what questions do you have?
So, John, there's a couple of them in the chat.
Awesome.
Let me see if I can pull it up here. So somebody said, so thinking about the amygdala response, this is Maris, thinking about the amygdala response when encountering a substance, is that primarily when you are around the substance or any kind of video or image, I'm just contemplating how on social media there will be memes or other images featuring substances. Would things like that also be triggering for people who are in the process of recovery?
Yeah, great question. So yeah, it's not just about the substance, it's about those images, those sounds, those things that are encounter. And, you know, social media and the internet has made that extremely challenging for folks. And so when you're working with individuals with substance use disorder, it is important that you talk through what are the skills that you need when you're triggered by these things. You know, there are some triggers that are external that we can help them manage, others that we can't necessarily help them manage, and that we'll need to give them a skill set to do so. So yeah, it's triggered. I mean, in that amygdala slide that I showed, it was actually a video that triggered that response. What's more impressive, and I don't think I said this when I was on that slide, is that the video, you know, they kept speeding up the using video to see if the amygdala would respond. And they actually got it down to like a flash to where the brain was actually had a difficult time consciously realizing what it saw. And what they noticed was even with that there was an amygdala response that was telling their brain to go use. So yeah, it's all these skills around relapse prevention and how to soothe yourself and what kind of support you need to when you're triggered. So great question, and it is a powerful thing.
Thank you. John, can I ask about marijuana and what is the, you know, there's an increasing availability of marijuana legally. And what is the treatment community's perspective on marijuana as an addictive substance? And because it's just everywhere increasingly.
Yeah, marijuana is the hot topic, right? And again, I mean, as a treatment provider, I see marijuana the same I see as alcohol and other drugs, even if they're legal. That just because you make it legal doesn't mean that it's not going to be problematic. And so there's going to be people who use marijuana recreationally and never have any big life impacts, just like there are people who maybe drink a beer and don't have a big life impact. But there is going to be a subset of folks who do struggle and who develop an addiction to cannabis and need effective treatment for that. I will say all the political stuff around marijuana legalization has made it more difficult to treat marijuana specifically. And what we're finding is that you don't want to put people with primary marijuana use in with people who have opioid or methamphetamine abuse unless they clearly see that the impact marijuana has had on them has had the same devastating impact as some of these others. So if you have somebody that's using marijuana, you know, one of the tricky features of it is the consequences of using marijuana happen over time. Whereas with heroin, methamphetamine, some of these other drugs, consequences are more immediate. So a person realizes it's a problematic. But with marijuana, it's more like a frog in water, right? It doesn't know it's boiling until it's absolutely overcoming. So we have a brief marijuana treatment program that we use at Oaklawn. That's 10 sessions. It's pretty effective for that. And, you know, sometimes they do need more treatment than that. But, you know, again, legal or not, people are going to have issues and we need to be prepared to treat it and competent in learning how to treat that differently than we do other things.
Great, thank you. James is asking if you could give examples of comorbid disorders.
Sure. So comorbid disorder would be you have a opiate use disorder and anxiety disorder, or you have an alcohol use disorder and schizophrenia, or you have benzodiazepines and bipolar. So, you know, again, it's that whole thing about having mental health issues right along with the substance use. There was a period of time in my training where, you know, the substance use treatment providers would say, oh man, you have to get your mental health straightened out before we can treat your substance use. And then the mental health people would say, oh, we can't treat your mental health until you go deal with your drug abuse. And then we went through a period of time where it's like, well, yeah, if we treat their mental health, their substance use will get better. And then the substance use people said, oh no, treat their substance use and their mental health would get better. Well, actually, what is evidence-based is that we treat both things at the same time with equal rigor. And so it's really important when they have a comorbid issue that you're not just focusing on one or another, but you're focusing on both.
Okay, thank you. Russ has a question. What about the dopamine said to be released in the Facebook indulgence? Is this an acceptable pleasure? And what about addiction to this activity?
Yeah, boy, that's an emerging question. There is, social media and electronic addiction and gaming addiction and all these things. We're seeing an increase in asking for those services. The other thing is a lot of these things are actually preempt a gambling use disorder, but that's a whole nother presentation. And what we're finding is that it does boil down to, does this interrupt your relationships? Does this interrupt your ability to do your job and fulfill your roles? And if so, then it's a problem. And we absolutely know there's a lot of dopamine and calmness that comes with looking at your phone. And people who like to zone out to deal with their anxiety are particularly prone to this. So it's definitely something that, we need to do a lot of prevention work on. We need to train young people on the appropriate use of those devices, and then monitor, when a problem is developed, how do we deal with that?
Okay. There are several other questions that have come in, so I'm going to try and get them in quickly. Matt's asking, what is your stance or thoughts on long-term programs such as Teen Challenge versus medicine or prescription aided recovery? Yeah,
great question. Again, I'll just say that there are multiple pathways to sobriety. And I know that there are folks who participated in programs like Teen Challenge that weren't successful with more professional treatment approaches, and the opposite is true. And I would say in both cases, the person has learned things in both approaches that can be helpful to their long-term recovery. I really like those programs that are faith-based and interweave treatment into it. I love those. And I think because it can kind of be the best of both worlds. But again, it's not about what I think is better. It's about what the person thinks is better for them right now. And both treatment approaches have their positives and negatives. And again, we just want to do what's best for the person.
Thank you. Stacy says, thank you, John, for acknowledging that trauma and substance use disorder go hand in hand and is best treated together. Thank you for including the neuroscience, which supports recovery and healing of both bottom-up regulation.
Yeah. Thank you for that.
John, how quickly can somebody get into treatment? If they, if somebody today were to decide I want to, enter a detox or outpatient treatment, well, how quickly can that happen for them?
Yeah, well, not quickly enough, but we have done some really great things to enhance that. At Oaklawn, we've developed a recovery cafe where Monday to Friday, people can walk in, get access to a recovery coach. And that recovery coach can kind of get them connected to the kind of treatment they want. We also have a quick response team, a line that is established for, quick response to an addiction where they can get a recovery coach, and I can give that number in the chat if you want. And then we also have an opioid mobile response that addresses people very quickly. And most of the time we get people in within a day or so, sometimes hours, depending on what's going on. I'll also say in this, in the state of Indiana, the inpatient resources have been really increasing, and very good access. You know, sometimes it does take a couple of days to get in, but there's a program called Open Beds that you can go to online that help you find those resources. Again, our coaches can help you find those resources. So we're getting better at treatment. And so you can get some response pretty quickly and then into the right kind of treatment you need pretty quickly too.
Okay. There have been a few questions about groups at Oaklawn, and what I'm going to be sending out later today are a list of resources, some of which John has referenced here. So, so John, if there's anything else you want me to include, just email me afterwards, and
Sure.
we'll make sure that everyone has access to some additional resources.
Sure.
John, this PowerPoint presentation also we're going to be sending out. So things that you presented people will have access to. And the recording for today, we will upload to our YouTube channel, the MHAM YouTube channel, and I will send all of that information out later this afternoon.
It's awesome.
Okay, so John, we are out of time. You packed a lot of information into this hour, and it was all, you know, really important information. So thank you so much for being here today with us, and thank you to everybody who participated. I apologize for the technology problem at the very beginning, but I'm so glad that we were able to do this. There is an evaluation that I just want to make sure people know.